The rationale behind BIVAL is that we think that we are able to restore epicardial flow very good in a primary PCI setting. What we also do know is that we still have significant large infarctions afterward. And that's mainly explained by the reperfusion injury and the no reflow in the smaller microvasculature of the heart. The effect of this is that we see progressive dilatation in 1/3 of our patients if we follow them up with 3-year MRIs. So we have to think that we have to improve reperfusion injury. So the large infarctions are partly explained by reperfusion injury and the no reflow. So in the setting of primary PCI, there's a lot of thrombin activity. It's released by the plaque rupture, but also if we modify it with the balloon angioplasty, there's coming up more thrombin activity. Now thrombin is, besides being in the coagulation path, it is also a strong inflammatory process. It increases vascular permeability. So we know that if we have to block thrombin more effectively, that we potentially could reduce reperfusion injury. The study design is aiming at primary PCI patients in an international study aiming at 200 patients. What we are doing is either give bivalirudin, a bolus, plus 4 hours infusions. These 4-hour infusions are important for the reperfusion injury. The control arm is just unfractioned heparin. The design has then MRI as primary endpoint at 5 days, and it will have additional parameters on biomarkers, microvascular perfusion with IMR. The major primary endpoint was infarct size. We did do an interim analysis after 78 patients, and we did see that the infarct reduction was really small. It was much smaller than anticipated, meaning that we were not going to reach our reduction of 23% as aimed at the design of the study. So we stopped the study after 78 patients. From these 78 patients, the infarct size reduction was 8%, which is non-significant. No significant reduction in infarct size. The secondary endpoints were very interesting. First, we did see in the biomarkers exactly what we expected. A significant reduction in TAT, which is thrombin-antithrombin complexes. That's one of the measurements. We did see a faster reduction in MPO, myeloperoxidases, meaning inflammatory effect during the first hours of primary PCI. We also did see a significant reduction in IMR, the index of microvascular resistance, measured at the end of the procedure, representing the microvascular structure. That was better with the bivalirudin versus the heparin. What we also did see was that at the CMR at day 5, the worst microvascular obstruction had a trend to be smaller than in the bivalirudin versus the heparin. Now, if the primary endpoint of the study is negative, there's no reason to change your current practice. But we think this is extremely hypothesis generating, interesting measurements, because what we have seen that bivalirudin is potentially reducing mortality. It has been some studies positive, some studies didn't see that. It's also on the design of the studies is important. Now, is that reduction in mortality related to the reduction in bleeding? But there was also reduction in mortality in the patients who didn't bleed. Now, we think that is because of the improved microvascular perfusion in this setting of using bivalirudin. The important thing is that you have to continue it for 4 hours, because this inflammatory process, this no reflow, this reperfusion injury continues for several hours. And that's why we think that only studies with 4 hours continuous bivalirudin are able to see an improvement. Now, to prove this hypothesis, we need a larger study, potentially aiming at either left ventricular function at 3 months, either in the end, of course, on mortality again.